Hey everybody, it's Kevin and Thea from RPH Ally, and we've got a really fun episode for you today. I think a lot of stars are aligning, so to speak. Thea, is that the right term? But
I
we have a
think
lot of
so.
things happening in healthcare that are really pointing toward how are we going to do more things for more people at home. And the specific element we're going to talk about today is the hospital at home program, especially for acute care. There is some concern that the waiver isn't going to be pushed forward, but there's some likelihood that it will in some way, shape, or form for us to continue a trend that we're seeing. But we really want to know what are the pharmacist roles inside of that? What are some of the challenges inside of it? And we'll discuss all of that right after this reel. All right. Thea, I guess to start things off, I was just thinking it's been way too long since I've seen Thea. So it's so good to see your face. I know that you've been
Yes.
busy, like hopping in and out of all kinds of different roles and responsibilities and hats. And I think that's really segues nicely into our episode today is there's a lot of roles, responsibilities, and hats, that we have had to shift and change with COVID. And so one of those was the hospital at home program that quickly went from nobody participating to now having over 300 hospitals participating, changing the entire way that we approach things and having technology companies pop up like crazy to be able to fill the gap on needs. And now we're also seeing another element that is what are the roles of everyone involved? What are the family members' roles? What are the healthcare practitioners' roles? And how are they doing it in a remote capacity? So lots to cover. But if we can, Thea, let's start from the beginning. I guess what are your thoughts when it comes to, hey, we have this pandemic, we have hospital beds that are way too full, and we have to find a way to be able to leverage this and utilize some kind of telecapacity. Do you remember those days and then what you were talking about in your hospital setting?
Oh, yeah, for sure. I mean, when we were getting in the middle of pandemic mode, it wasn't a few hour wait for the next bed. It was days, if not a month, to get an ICU bed in places. And it's just, they had to figure out a different way. And a lot of the bigger health systems did. The smaller health systems, like where I am, we didn't really have a lot. I mean, we were able to continue care pretty quickly. It was a few days, maybe, into the ER stay, but they were able to triage correctly and do it. But a lot of facilities didn't have that opportunity and they were slammed with patient volume. And so when that happens, we have to think outside the box. And this program has been in place for a long time, but no one, like you said, wanted to use it because of the payment model. And so bringing in the fact that under the pandemic, we had opportunities to go get those waivers and really make it a possibility to see what it could really do for our future. And I think it's delivered. I really feel like it's a unique way to carry the load maybe more at home than necessarily on healthcare providers in and of themselves. But I think that it definitely lends itself to more acute care for those that are maybe a stable acute patients that aren't exacerbation mode of, like I can't breathe at all, or it's a struggle, but I'm still doing okay, kind of care. I think there's a lot of in between that we can get covered by programs like this at the healthcare at home or hospital at home programs.
Yeah, I think there's an interesting balance. And one thing that I don't think we talk about enough is being in the hospital isn't perfect for everyone. In fact, sometimes
No.
it's deleterious, right? There's even studies showing that these hospital at home programs are showing even better outcomes for patients. And if anybody has been in the hospital, and thank you everybody for joining us today, any questions, shoot them our way. If anybody has been in a hospital setting with family members or themselves, you are never comfortable, right? You're being
No.
woken up around the clock, the monitoring, the drug administration, nothing is ever sunk the right way so that you're getting everything taken care of. We're not leveraging some technology to be able to monitor things. We're still doing old blood pressure cuffs and coming around and waking someone up in the middle of the night. A lot of things that are honestly very antiquated, but make it difficult to be there, let alone you're not in your same bed. You're not comfortable because you're in this weird gown that you have tied in the back. So all of
Yeah.
those pieces just alone, add a ton of benefit to moving someone at home. The other piece, though, that you and I both know this, Thea, from working in hospital settings, there are studies that show it, but anecdotally, even, if you bring a family member with you as an advocate, or if you have a family or friend there in the hospital setting, you will have a better experience. And
Yes.
I've seen that over and over and over again. It is not a testament against anyone, not our nursing staff, not our providers, that they're not doing their jobs for the folks that don't have family members there. But it is really a squeaky wheel component and another set of eyes, to see
Yes.
how an individual is doing, how they're responding. Those family members know them and their disposition better, that they can sense some changes and other alterations in mental status, et cetera, more quickly, and observe those kinds of comfort elements that are also helping with the healing process. So that's another factor, that I can see why we're adding on to pushing toward healthy individual. Just off show, Theo's like, the interesting component to this is it really ties so many strings together of, we're looking to make sure that keeping primary care primary and focusing on our elderly populations and more chronic disease efforts in terms of reimbursement. This one falls right in line with having hospital at home kind of services, especially as Theo was mentioning, really looking at which conditions are chronic exacerbations that are leading someone to a hospital versus acute ICU incidents that we're monitoring and making sure someone's being taken care of. I'm going to pull up real quick, Thea, this for us to kind of read through and then, jump into the next topics about our conversation. So let me just add this. In the meantime, that NPR article that I pulled up, Thea, and we were talking about before the show, I'd love to get your thoughts and commentary on the opposite side, the concern that we could put more caregiver burden on family members. You and I have talked about CHWs and some of the additional caregivers who are trying to implement the system to lower overall costs. And there is some concern from individuals that now we're going to be reliant even more heavily on individuals that are in the home, be able to expand and stretch out our FTs when it comes to nursing staff and other clinical members, and unfortunately tax those individuals that, they might not be able to take a day off of work. What are your
Right.
thoughts there? How we can combat that?
Yeah, I think there's got to be some kind of a model that helps educate and support the caregivers at home. There are, new initiatives through care management services that they're looking at to really help with that. But I really feel like it is something that we need to think about, because not all of them are going to be an educated healthcare provider. And so what does that look like? How do we support them and educate them? And I think care management services, whether remote or not, will definitely help with that. But I don't think it's going to be the model that's going to help sustain a program like this. There's going to have to be some, maybe even reimbursement for those caregivers, like in other countries where we don't have long-term care facilities. And, how are we aging at home, and what that looks like from even maybe legislation and CMS's standpoint.
I agree. I saw California is doing something very similar, having those caregivers starting to have a reimbursement model go in place. And here's some of the elements that we know that is how we were founding this hospital at home kind of model during the pandemic. But just reading it to everybody, that first paragraph there: participating hospitals will be required to have appropriate screening protocols before care at home begins to assess both medical and non-medical factors, including working utilities, assessment of physical barriers, and screening for domestic violence concerns. So that's very similar, Thea, to what you and I have talked about with the audience that's out there. Is within RPM and CCM, especially RPM, the ability for someone to be connected to those devices and the ability for them to utilize the technology and having a disease state that is monitorable and modifiable with the technology is an important factor. Very similar here. We're doing some triaging and we're making sure that we have an appropriate surrounding for those individuals to be in, to be safe in a hospital home setting. Next piece is the beneficiaries will only be admitted from emergency departments and inpatient hospital beds, and an in-person physician evaluation is required prior to starting care at home. Ding, ding, ding. Same exact thing that we're seeing with all the other remote care services components. We need a visit to established care with an established provider. We're just trying to lay some groundwork to make sure that all the necessary clinical dots have been checked, or boxes have been checked, and I's have been dotted on there.
Yeah, and I think, just one second there, Kevin, and I think that it's important to remember that if we're looking at hospital at home, we need the hospital's input on that, because who are we going to triage to but that hospital provider, is what I've seen previously. So it's allowing us to stay at home, but still have the outreach if needed and when needed to be able to reach that physician that has prescribed me to get hospital at home services. And so I think it's more than maybe just an establishment of responsibility here from a established patient relationship. But I think it then leads itself to, if it is truly something that they need to come in for, they're going to be one step ahead of our ER and not have to come in through the ER and go right into an opportunity to be under the care of that provider.
Yep. Yeah, I think that's entirely perfectly said. And I think the last piece was only related to how often are the checks going to be. And so there's requirements for daily nursing check and twice daily using a mobile integrated health paramedic, which we can talk about at a later date. But it's really based on that plan that you were just talking about with that physician to make sure, can we do this at home, and what is the schedule necessary to be successful inside of that home-based model and system. Okay, so with all those things kind of being said, Thea, what's the future of it? And what are pharmacists' roles going to be in it, related to the technology that's being deployed and some of the other models that you think are necessary for pharmacists to play a major role?
I think a lot of it comes around medication management. With these acute stays at home, they're going to have new medications. And what does that look like? They're going to need IV antibiotics and IV medications. What does that look like? How do we get there? How do we help and assist with that? Yes, nurses are very capable of doing that. I agree. However, I don't think that they're going to have the expertise to vancodose. I don't think they're going to be able to renally dose stuff. Do they know it? Yes, but is it their wheelhouse? No. And I think there's ways for us to stand up and really show our value here and use our clinical knowledge as part of what is going to need to be happening in the home sector. When we look at hospital at home, really is our ICU kind of beds. And so you and I both know, Kevin, that there's ICU pharmacists. Like, why wouldn't there be a pharmacist at this table and really helping with the rounds of these patients? And okay, it might be a telehealth remote round, but does it matter? Nonetheless, it's going to have a clinical team member there at the table and really showing up to protect the patient from medication errors from those people at home that are not clinically trained. Is it going to be able to offer education more so than maybe what is on the monogram to give to the patient and what that looks like? And so I really feel like there's a way that we can come to the table for this to really help augment the program and make it valuable, because pharmacists, like no other healthcare, in my humble opinion, can meet a patient where they are. That's our job. That's what we do every day in the pharmacy sector. So why not do it here?
Yeah, I totally agree. And I think that we're at a really interesting intersection between chronic care, right? We're in the home. We're literally in the home where they're going to be living out their days, and acute care. And so the ability for a pharmacist to play a role in not only what is being prescribed today related to their acute care management, the diagnoses that are at the top of their chief complaint list, but also all of the other medications that they're currently taking or going to continue taking. We can play a bigger role in doing the entire comprehensive medication review for those individuals and be able to help them with the home-based delivery of those medications. So if it's leveraging technology, God bless you, if it's leveraging technology inside of the home to be able to track those medications and when they're being administered so that our MAR can stay updated and we can keep our patients safe when they're administering those medications themselves or through a caregiver, depending on what needs to be monitored, how does it need to be monitored, who's checking in on those monitoring parameters, if it's a lab draw, if it's related to efficacy or, post hoc analysis of what happened here, what was given, what standing orders are in place. Not as easy to execute a standing order when you don't have your nursing staff that has been doing it for 20 plus years. Another interesting piece really this is a lot of times, one thing that I was reading and listening to podcasts on, the nursing world is seeing a shift on who is providing this care, this kind of acute care. Is it the most experienced nurses that are out there, or is it new nurses that are coming in with less seasoning, under their belts? And we're still dealing with hospitalized patients. And so I'm seeing a bigger push that some of the later stage career nurses are starting to come back and be leveraged inside of these spaces. And I think it's a really interesting call out for those pharmacists that are highly experienced in utilizing their acute care skills and clinical skills to be able to be leveraged inside of these settings, because they're an even more vulnerable patient to a certain extent because they're not under the consistent and constant guise, of the entire care team. And so now having a more experienced pharmacist with decades potentially of experience under their belt of seeing disease state management and modifications of therapy could be a real advantage, on how to staff these individual models. But what are your thoughts there, Thea, on how the monitoring elements could potentially steal some thoughts from chronic care management, RPM, RTM, and leverage pharmacists in that capacity in the hospital home?
Yeah, I mean, I think it's a great place to get that information flowing to the health systems, that pharmacists, whether you're in an independent pharmacy, whether you're a consultant pharmacist somewhere in the mix of everything, or maybe you're a hospital pharmacist that wants something different. That was me. I mean, I played all three of those roles, right? Like I wasn't ever the career satisfaction wasn't there. And so when you get to care for patients like we know how to do, meet them where they are, take them down their healthcare journey, plus get data back to the providers that need to see it and understand what is going on for the patient. I mean, I just think it's time for pharmacists to show up. And I think this is a great opportunity to really look at this. And I know a lot of independent pharmacy owners are looking at this medication at home model anyways. And so what does it look like to take your seasoned pharmacist that has plenty of experience and put them into a more clinical role to help monitor those medications at home? And that may be a starting point into a hospital at home program. But I think utilizing the technology that is all around us is, if nothing more, COVID has shown us the possibilities are endless to be able to show up for patients in a different realm and see the value outcomes. And it is all there, whether it is just an outreach via telephone from a pharmacist once a month, or maybe it's once a day for these medical at home patients to really feel the value that they are being heard. Because when we look at those surveys coming back from patient engagement, that matters. That is a heavily weighted quality metric. Is the patient being heard? And can they get their questions answered? Well, why not have a pharmacist right there answering those questions? We're there, and programs like the remote therapeutic monitoring, when we get that to be a medication driven program, like we're all pushing for, the technology is behind us saying we are ready to jump on these codes and be able to really help the therapy at home from a medication standpoint. And why not get there? Those pharmacy owners or pharmacists out there wanting more, this is a great place to keep up to date on, because there is so much potential here. Even when we look at what we're looking at in aging at home, if legislation goes to aging at home, it's going to be all over the place because we can't staff long-term care facilities. So what does it look like? It is an entirely different practice model, using nothing but our expertise and clinical knowledge and sharing what we know and how to meet patients where they are. So, I mean, whether it has data behind it or the future of therapeutic monitoring, or maybe even just the outreach from a clinical pharmacist each and every day for these medical at home beds, I think the potential is there for anyone who wants more out of their career. It's here.
Yeah, I think the interesting things to me, Thea, are the things that aren't there too. So I think that talking to a couple colleagues that are doing some home visiting, and pharmacists in particular doing a home visit and assessment, I asked them, is there a way we could do this at a remote capacity and potentially do it through another staff member? And the answer is no. And then I said, well, what if? And then the other answer was no. So basically what the individuals doing this study were seeing is there's no way to replace a seasoned pharmacist from going into a home and being able to assess the elements that are not thought of by other individuals and the signals and signs that are issues that could pop up. So for example, storage of medications. You do not have a humidity controlled storage environment inside of these spaces. You do not have controls and bells and whistles to be able to alarm you when there could be a diversion happening for these individual patients. You don't have the ability to keep out other therapies like you do inside of an individual hospital bed or stay. You're discouraging anyone from bringing into the room. You're trying to control everything to flow through the individual nurses. Now you're putting some autonomy back to the individual patients. And if they have something in their medicine cabinet that they think could help, that could be something they're moving toward. If that something is expired, they could also be going toward that. In the exact same controls of, what pieces of technology are being put in place to be able to monitor the administration of these individual drugs, and then how that's being relayed back to the pharmacy and rest of the clinical staff. has to be an expert pharmacist looking at what are the problems and loopholes that we can see with each of the pieces of technology, and how do we try to accommodate for those. And so I think, once again, another great place to have pharmacy put their foot down and say, we need a pharmacist assessment. Like, we need a pharmacist to go out to each one of these beds and make sure that from a medication delivery standpoint, from a treatment delivery standpoint, we have everything that we need to and checked off the list. That is not just a physical list that you can have anyone in the family go and check off, but one that an expert that has been doing it and is trained in treatments and medications can do it better than anyone else can. So there's my soapbox on that piece. Thea, any thoughts there?
I like it. I mean, I think that there are a lot of people that would come to the table and say they could do the same. However, what expertise are you going to get? What other opportunities are you going to get to share with that patient? So I think pharmacists meet patients where they are and listen intently. That's our whole delivery model on everything they teach in school today is, are you listening? And are you engaging? And that is us. That is who we are as professionals in the healthcare arena. And I just wish more people saw that value, because there will be people that say, nah, not a pharmacist. We got more valuable things for them to do, but we're not going to give them provider status. There's my soapbox. There we are.
Yeah, I think the more valuable things to do is an interesting piece. When it comes to who is going to take on what responsibilities and what training is behind those individuals to take those responsibilities on. And I think that really is at the root of all of these issues we're encountering is reimbursement. How are you being reimbursed to be able to get an individual out and leverage inside of a community? And I think there has to be, just like these waivers caused a level of equality from hospital stay in hospital versus hospital stay inside of a home, there has to be that exact same kind of thought process when it comes to leveraging clinical staff members inside of these settings and making sure that they're being used at the highest level. And we already mentioned that in an ICU stay, we're seeing rounding of an entire collaborative team. And so that, once again, really leans back to the necessity for that clinical team to be leveraged. I'm all for the eyes and ears to be not a pharmacist every single day, right? I mean, I think there's some cost-based elements that makes sense, but there is some real utility to leveraging our profession when it comes to a lot of these elements that just can't be taught, right? There's something that you're looking at a doctorate level of experience to catch on. And so I think there's my push there for hospital home. I think that pharmacists can play roles in not only reviewing and breaking down the medications, the medication safety elements, coordinated care efforts and monitoring components inside of a hospital home model, but also we need to put our foot down for pharmacists needing to be involved in the care for those individuals that are hospital at home. And when it comes to clinical documentation, when it comes to evaluating regimens, I think there's an interesting place here that instead of saying, let's stick with the status quo and make it just like any other hospital bed, it's not, right? It's not. We can't treat it that way. And I think that's why pharmacists play an even bigger role in this space.
Yeah, I agree. I love it. I'm excited to see it grow, because it will.
Oh, me too. So next week, everybody, if you guys have any questions, and I see that Dr. Singh has left us a couple messages on there. Thank you so much. And he says here, how to minimize irrational use of antibiotics in developing countries like mine in Pakistan. We are observing a lot of irrationalities that are deliberately done by authorized physicians. So there's another great place, antimicrobial stewardship, when it comes to the use of what antibiotics are being used in the home, what has been previously utilized, and what can we do to make sure that we're good stewards of all the resources we have to minimize the therapies that are being given to our patients and the side effect profiles. What a great call out. So thank you for that, Dr. Singh. And another great call out by Thea is really going to be next week. We're going to segue this all from hospital home and some of the undetermined roles of pharmacists and shift over, Thea, to
the rising star in the pharmacy world, and it is remote patient care. It is here, ladies and gentlemen. Let's get on the boat, because it is going to go fast. I'm super excited to also share that my Pivot program is up and functioning. So we are live with the Pivot program, which really allows pharmacists to take a look at what those value-based care opportunities really are in the pharmacy world. So if they're looking for more of that, we'll make sure that we add the link here in the show notes as well. But it is tmrx.care/pivot program. We'll get you there and let you take a look. Lots of great information in there on how to do just what we do, and share the knowledge that 5 years of experience has brought me to today. So I really hope that if you have any questions for us, please bring it, and we'll talk more about the Rising Star in Pharmacy next week.
Amazing. Well, that sounds perfect. Thank you guys for all joining. Hope you're excited about hospital at home and how that can impact our patients and our profession, and trying to become a larger part of that in your individual organization. So any questions, shoot them our way, and you guys have a wonderful rest of the day.